Good evening, everybody, and welcome to another edition of the Resident Smart Learning Program. Today, we have a very important topic, which is very common that you will encounter these patients. It's a case-based approach in the management of male lower urinary tract symptoms due to benign enlargement of the prostate. And this would be very important for all the residents to know how you will manage these lower urinary tract symptoms. And to deal with this, we have Dr. Neely, who is the professor and head of the Department of Urology at the JNMC Belgaum. And Dr. Arun Chawla will introduce him formally. And I also welcome Dr. Prashant, the Honorary Secretary of the West Zone USI, who has joined us. With this introductory remarks, I hand over to Dr. Arun Chawla to introduce the speaker and they convene the session. Over to you, Dr. Arun. Arun, over to you.
Thank you, Dr. Keshav. A very warm welcome to all the residents and the USI members for this Smart Learning USI-ISU program. And I have great privilege in introducing today's faculty, Dr. Siddhalingeshwar Neely, to you all. Dr. Neely has studied his MBBS in Karnataka Medical College, Hubli, and then his post-graduation surgery was from BJ Medical College, Pune. He did his 3-year residency program in urology from a prestigious Topiwala National Medical College and PVL Nair Hospital, Mumbai. After his MCH, he joined JNM Medical College, Belgaum, as assistant professor, and currently he is a professor and heading the department. His keen areas of interest include urology, reconstructive urology, and laparoscopy. With more than 25 publications in peer-reviewed articles, he has authored a chapter in guidelines for surgical emergencies. He has presented many papers and posters and chaired scientific sessions in regional, zonal, and national conferences. Organizational post at state level and zonal level, he has served as honorary secretary of Karnataka Urology Association and a council member of Association of Southern Urologists. Dr. Neely will be talking about case-based approach in the management of male LUTS due to BEP, and Dr. Keshav already mentioned how important is this topic. Whether this comes as a question, a full question, a short note in any of the 4 papers, it can be on symptoms, it can be on urodynamics, indication of urodynamic, it can be on various questionnaires used, it can be on drugs. But what he'll be doing is he'll be talking as a case-based discussion. That's how you deal in your OPD and the wards. I'll request all of you to stay proactive, and if you have any question, put your question in the queries in the chat box. We'll be taking answers to these after the class is over. With this, I formally invite Dr. Neely and welcome him for today's Smart Learning Program. Over to you, sir.
Thank you, Dr. Chawla, sir. At the outset, I would like to thank USI and ISU for giving me the opportunity to be part of this Smart Learning Program. And I thank you, Chawla, sir, for the kind words which you have bestowed on me. We'll directly go to the topic. This is basically a case-based approach in the management of male LUTS due to BEP. I don't have any disclosures to do. The objectives of this.
No, you have to share your screen. We are not seeing your screen.
Sorry. Okay. Share.
Share. Share again.
Yes. I'll. I think you'll be able to see, sir, now. Is it visible, sir?
Yeah, we are good to go.
Yeah, okay. Nearly is visible. Good.
Okay. So basically, the topic is case-based management of male LUTS due to BEP. The objectives of this are how to use questionnaires in the evaluation of male LUTS, how to investigate a patient with male LUTS in male patient with LUTS, indications for urodynamics, and medical management, which, when, and how to give individualized treatment. First, we'll have a brief discussion on all these topics and then go for a case scenarios and how to utilize the knowledge which are learned during this program. So, what is LUTS? LUTS is basically a term, the lower urinary tract symptoms is a term of convenience that encompasses storage, voiding, and post-micturition problems. It is not a diagnosis, it is just a term. But these symptoms have a significant impact on the quality of life. These symptoms may originate from either bladder, urethra, prostate in men, and or adjacent pelvic floor or pelvic organs in females, and at times may be referred from similarly innervated anatomy, for example, the lower ureter. So what are these symptoms? We have basically filling symptoms or storage symptoms, and emptying or voiding symptoms, and post-void symptoms. Among the filling symptoms include frequency of micturition, urgency, nocturia, urgency incontinence, stress incontinence, nocturnal incontinence, bladder or urethral pain, and absent or impaired sensation. Amongst the emptying or voiding symptoms, we have hesitancy, which is basically latency to initiate the act of micturition, straining to void, poor stream or weak stream, and intermittency, dysuria, and terminal dribbling of urine. In the post-void symptoms include post-micturition dribble, feeling of incomplete voiding or incomplete emptying of the bladder, and post-micturition incontinence. Amongst these, the one which are marked in yellow are included in the EUS symptom score, that is the frequency, urgency, nocturia, hesitancy, poor stream, intermittency, and feeling of incomplete emptying. And these which have been marked in the red are included in the overactive bladder symptom score. That is frequency, urgency, nocturia, urgency, incontinence. Now, what are these lower urinary symptoms are of multifactorial etiology. It can be because of prostatic enlargement, it can be because of bladder pathology, some foreign bodies in the bladder, bladder tumor, or it can be because of the inflammation, and it can be because of systemic symptoms, because of polyuria also. So there's a multifactorial etiology which is responsible for lower urinary symptoms. When we talk of only lower urinary symptoms, they are non-specific. They can occur both in men and in women, and they are caused by many conditions, and it just describes ailments without implying their cause. Coming to pathophysiology of the lower urinary symptoms, primarily because of BPH, what we are dealing with today is when there is hyperplasia of the prostate, it may lead to bladder outlet obstruction. And this outlet obstruction will cause a detrusor response, making the detrusor work more to overcome the obstruction, which may be responsible for the hyperactive bladder. And together, they form the lower urinary symptoms. But in addition, the patient may have other causes for outlet obstruction. It may have other causes which may affect the detrusor response, or he may also have polyuria, which can give rise to lower urinary tract symptoms. So when we take all men aged more than 40 years, majority of them will have histological BPH, that is benign prostatic hyperplasia, out of which very few might have symptoms which have clinical enlargement of the prostate, and few will have bladder outlet obstruction, and some may have lower tract symptoms. So this, if you see, what we are primarily concerned is this part where they have enlargement of the prostate as well as causing lower tract symptoms. So how to evaluate these patients? The most important thing in evaluation is taking a detailed history of the patient, including the relevant comorbid conditions, which may be medical or neurological, which can contribute to lower tract symptoms. Also, we need to take a detailed history of medications which can increase the urine output or may affect the emptying of the bladder. Like the patient may be on diuretics, which can increase the output, or patient may be taking some cough syrup and all, which may affect the outlet and may be responsible for retention of urine or incomplete emptying of the bladder. other important thing is to ensure the lifestyle habits like excess drinking of water or binge drinking of fluids like beer intake or alcohol intake, or some patients may be habituated to drinking excess tea and coffee, which can give rise to diaries as well as increase the urine output. So all these need to be documented. We need to also give importance to emotional and psychological factors, which may make the patient visit the washroom again and again and may be responsible for his lower tract symptoms. So a complete medical history of men is important in assessing the lower tract symptoms. And this is strongly recommended by the UA guidelines. So when we assess the symptoms, we should also make at the same time a therapeutic pathway, like how to deal with all these conditions which are responsible for the patient's problems, as well as to reassure the patient that there is no definite link between LUTS and prostate cancer, which most of the patients are concerned about. So to evaluate the symptoms, primarily the lower tract symptoms, we make use of symptom score questionnaires. What these do, these help us in quantifying the lower tract symptoms. They identify which type of symptoms are predominant, whether it are storage symptoms or voiding symptoms, or they are post-micturition symptoms. These symptom scores are not disease or gender specific, or not. They are also not age specific. They can be utilized for all kind of pathologies causing the lower tract symptoms. They can be used in both men and women, and they can be used for all age groups. They are sensitive to symptom changes, so they help in assessing the patients even after initiation of the therapy, so that we can see how the symptoms have changed or how the treatment is effective in changing the symptom score. So the EAU also strongly recommends use of symptom score questionnaire, to which these symptom scores may help us in assessing the amount of bother which the symptoms are causing to the patient's life, as well as the quality of life which has been affected by the symptoms. We use various symptom scores. The most common and predominantly used symptom score is the IPSS symptom score, that is interstitial prostate symptom score, which has 7 questions and 1 quality of life questions. Amongst the 7 questions, this includes incomplete emptying, frequency, intermittency, urgency, weak stream, and nocturia, straining and nocturia. And it also, the last question is about the quality, how the quality of life is affected by all these symptoms. So once we score the patient, means actually this symptom score has to be filled by the patient, and we have to just tabulate and see how much symptoms the patient is symptomatic. So we score them into, we categorize them into asymptomatic patients if the score is 0, be mildly symptomatic if the score is 1 to 7, if moderately symptomatic score is 8 to 19, and severely symptomatic if the patient has a score of 20 to 35 points. The limitations of this IPSS score is it lacks the assessment of incontinence, which is one of the primary symptom of the lower urinary tract. It also doesn't take into consideration the most post-micturition symptoms, and the bothersomeness of by each symptom is not taken into consideration. To overcome this problem, the other symptom scores which are used are IQM, LUTS. For uneducated patients, the visual prostate symptom score can be utilized, where the symptoms have been depicted pictorially. Like this shows the daytime frequency, how often the patient has to go, and this is the nighttime frequency. This is the stream, whether it is good stream or a poor stream, whether there is a dribbling of the urine that has been depicted in this one, and whether the patient has to rush to the toilet. So all these have been depicted pictorially, and whether how the patient's quality of life is affected, whether the patient is badly affected or whether his patient is having not affected by these symptoms. So the international consultation on incontinence questionnaire, that is MLUTS, is primarily meant for males, male patients to assess the lower tract symptoms. It has a full form and a short form questionnaire. In the full questionnaire, it constitutes 22 questions, but most commonly uses short form SF questionnaire, which constitutes 13 questions. 13's this one out there, but each question has also takes into consideration how much the patient is bothered by their symptoms. The symptom is scored by 0 to 4, and the bothersomeness is scored from 0 to 10 for each question. So it has 13 items in the short form. So, and on a subscale of 0 to 4. So it has been validated in 17 languages, and each symptom has a bothersome score. The limitation of this is too extensive for the patient to fill, and other thing is does not address the pain symptom. So other symptom score which has been utilized is the Danish process symptom score, which is not commonly used. It has 12 questions, but it takes pain as a dysuria also into consideration, as well as post-void dribble into consideration. So each question is scored from 0 to 3 for severity, and for bothersomeness from 0 to 3. A composite score includes a symptom score multiplied by bother score. So the range of the total score ranges from 0 to 108. It has an excellent retest reliability, but it doesn't correlate with the obstructive score. The obstructive score doesn't correlate with the pressure flow studies. It also cannot predict the success or failure of DRP, but it is a very good scoring system to assess the lower tract symptoms. The other score system which was proposed to improve upon the IPSS was a core lower river tract symptom score. It has most of the symptoms of the IPSS. In addition to that, the bladder pain and urethral pain and also urgency incontinence have been added to the IPSS. It also has a very good retest reliability, but it is not being validated in other languages. In addition to that, we can use overactive bladder symptom score in patients having overactive bladder in secondary to BPH. So basically, the symptom score questionnaire is a trade-off between the clinical priority of completeness of assessment versus the important factor for patients, that is ease of completion. If the patient is easily able to fill the score, then it is much more useful. At the same time, it will be helpful for us to assess the lower tract symptoms of the patient. Currently, there is no gold standard questionnaire which has been recommended. The most useful, better evaluation tool is the ICU-IQ MLUTS, because it covers a broad range of symptoms, and it is patient-centered. So ultimately, all these symptom scores help us in understanding the lower tract symptoms, how much each symptom is bothering the patient, and how our treatment will help in reducing the symptom, so that we can plan a treatment for the patient which is patient-centered and customized to the patient. In addition to history, what is most important is the physical examination, which includes distal rectal examination. Primarily, focus is on the suprapubic area for a palpable bladder, the external genitalia to look for any phimosis or any meatal stenosis, the perineum to see any scars which may, or also palpate the urethra for any strictures, and focus neurological examination to see whether there is any neurological problem which is contributing to the detrusor dysfunction. We should also look for any urethral discharges and any malignant growths in the external genitalia. So a distal rectal examination is to assess the prostate, basically to look at is the consistency, the tenderness, the volume of the prostate, which can be roughly assessed by distal rectal examination. Also, at the same time, the anal tone and the perianal sensations can be assessed. According to the EAU, the physical examination has been strongly recommended. The next important contribution for our assessment of the lower tract is the frequency volume chart, or commonly called the bladder diaries. Now, these diaries have to be maintained by the patient. We have to counsel the patient and teach them how to maintain the diaries. Basically, they have to maintain the intake as well as the output, the number of times they void, the volume of urine they void each time, and it has to be documented immediately. So there is no role for recall bias in these bladder diaries. So usually the bladder diaries have to maintain for at least for 3 days or more, so that the variations in the intake and output of the patients can be nullified. The ICIQ bladder diary is the only diary that is fully validated. The EAA strongly recommends maintenance of the bladder diary to assess the male lower tract symptoms. Once we understand the patient's symptoms, next is to evaluate the patient. The most commonly recommended is the urine analysis. This will help us in ruling out glycosuria, microhematuria, and urinary tract infections. So even though it can be optional, if the patient doesn't have any symptoms, it can be omitted, but it's not very costly investigations. So most of the guidelines, they strongly recommend doing a urine analysis. Next is imaging. The most common imaging utilized is ultrasound examination. The ultrasound examination can be of prostate, the bladder, and the upper tracts. It's not a mandatory investigation. For prostate examination, we can use either transabdominal ultrasound or a transrectal ultrasound. The transrectal ultrasound is preferable because we can assess the prostate volume accurately. We can also do a transition zone index assessment, a presumed circle area ratio, where we assess the prostate to be whether it is circular or close to a circle. A ratio has been is devised to see whether the length and the prostate on a cross section matches the circle. And we can also assess the prostatic urethral angle and intravesical prostatic projection. These things, the transition zone index, presumed circle area ratio, prostatic urethral angle, as well as intraprostatic projection, they are indirect tests of urodynamics. They indirectly indicate whether there is a possibility of bladder outlet obstruction or whether the prostate is causing outlet obstruction. If the EAU has a weak recommendation of doing imaging for all patients, but it is a strong recommendation prior to considering surgical management. When we assess the bladder by transabdominal examination, we look for intraprostatic projection of the prostate, we look for bladder wall thickness, and we can estimate the bladder weight using ultrasound. We can also find out other pathologies like vesical calculi or any growth within the bladder, and we also make a documentation of post-void residual urine. Now, amongst this, the intravesical prostate projection, bladder wall thickness, and residual urine are again indirect urodynamic assessment of the lower tract. So the diagnostic accuracy of these is very poor, and it also depends on the threshold at which we fix. For example, if the post-void residual urine has with a threshold of 50 ml has a positive predictive value of 63% and a negative predictive value of 52% for bladder outlet obstruction. The evaluation of the upper tracts by ultrasound is indicated in patients having large PVR with history of hematuria or history of urolithiasis. The ultrasound is also indicated in patients having renal insufficiency. The next common investigation which is utilized in the outpatient department is the uroflowmetry. It's a widely used non-invasive urodynamic test. The key parameters which are assessed are the maximum flow rate as well as the flow pattern. Now, with when the threshold of maximum flow rate is 10 ml per second, then we can identify bladder outlet obstruction with a specificity of 70% and positive predictive value of 80%. When the same thing, when the threshold is increased to 15 ml, the specificity as well as positive predictive value drops to 38% and 67% respectively. The specificity of uroflowmetry can be improved by repeating the flow rate testing. By retesting, we can improve the specificity by taking the average of the test. The most important thing which we need to understand is whenever we assess this uroflowmetry, the minimal voided volume of urine should be at least 150 to 200 ml. Uroflowmetry can also be utilized for monitoring treatment outcomes and correlating symptoms with objective findings. However, the EAU has a weak recommendation for initial assessment of LUTS, but has a strong recommendation for uroflowmetry prior to medical or invasive treatment. The next investigation which is utilized is the lower tract endoscopy, which is not being utilized routinely, but however, it has to be utilized when we suspect other conditions which may affect the outlet. like comorbidities of the urethra and urinary bladder, like Stitcher disease or meatal stenosis or a vesicle calculus. So it also helps in estimating the prostate size by assessing the prostatic urethral length and also looking at the morphology of the prostate. We can assess indirectly the amount of obstruction by noting the bladder trabeculations. But however, the trabeculations have very poor correlation with the maximum flow rate. But they have been shown some correlation with urodynamic parameters like detrusor overactivity and low compliance. The higher the more the trabeculations, higher the chance of having detrusor overactivity as well as low compliance of the bladder. The EAU recommends to perform cystoscopy in men with LUTS prior to minimally invasive or surgical therapies, not as a routine initial evaluation. The other commonly utilized investigation is serum PSA. Serum PSA is a marker for prostate cancer. However, it's also a strong predictor of prostate growth. It also predicts changes in symptoms, quality of life or bother, and Qmax. The higher the PSA, higher the chance of having poor quality, higher the chance of landing with more complications of benign prostatic obstruction. The rationale for using PSA as a evaluation tool is, one is to screen for prostate cancer, another one is to prognosticate for progression of BPH as well as response to treatment. The EAU also has a strong recommendation for measuring PSA if a diagnosis of prostate cancer is suspected, or if the PSA is also been recommended to measure PSA if it assists in the treatment or in the decision making. The renal function measurement by measuring serum creatinine or measuring the estimated GFR is utilized only in patients having comorbidities or in patients of suspected CKD or chronic kidney disease, or where the patient has a large PVR, post-void residue, which may affect or may cause hydronephrosis and eventually cause renal insufficiency. It is not a routine investigation, it's an optional investigation in the initial assessment of patients with LUTS. The MTOP study shows that the de novo risk of renal failure in patients with LUTS is less than 1%. That's why the measurement of renal function is optional in the initial assessment of LUTS. So why do we need to evaluate all these things? The basic criteria is we want to identify patients who can progress. All men aged more than 40 have histological changes of prostate enlargement. Majority of the men may progress to clinical enlargement, but we are interested in patients who can progress to complications of the BPH, or who may present with outlet obstruction, or who can end with retention of urine. So the cumulative study, the Olmsted County study, it shows that higher the age, severe the lower tract symptoms, higher the prostate volume, and poorer the flow, they tend to land with acute urinary retention. So same thing is, again, if the patient has, in the MTOP study also, in the placebo arm, it shows that the progression is higher if the patient is more symptomatic. Then what is the role for urodynamics? What is urodynamics? Urodynamics is the measurement of physiological parameters relevant to the function of the lower urinary tract. Now, the lower urinary tract has to store the urine at low pressure and has to empty the bladder when it is full without abdominal straining. Now, this is being documented by assessing the lower, by doing the urodynamics. In addition to assessing whether the function is normal, it can identify whether the bladder, there is outlet obstruction, whether the detrusor is overactive or during the filling phase, whether there is underactivity of the detrusor during the voiding phase, or whether the compliance is reduced during the filling phase. So urodynamics help us to identify factors which can contribute to lower urinary tract. It gives us it also helps us in predicting the patient's who have poor urodynamic parameters, which can affect the upper tracts. It can also help us in identifying the patients who need urgent treatment, or it also helps us in evaluating the patients who have failure of the previous treatments. So basically, it helps us to guide therapy and improve the outcomes of managing the patients with lower tract symptoms. So there are various types of urodynamics. One is non-invasive urodynamics, other is invasive urodynamics. Already we discussed few non-invasive urodynamics in the form of bladder diary, post-viral residual urine assessment, uroflowmetry, and ultrasound, which also helps us as indirect urodynamic assessment of the bladder in the form of intravesical projection of the prostate urethral angle, and bladder wall thickness, and estimated bladder weight. Also, other non-invasive cystometry is the cuff cystometry, which is rarely been practiced. The EAU does not offer non-invasive test as for assessing the lower tract symptoms. Then comes the invasive test, that is a commonly utilized the pressure flow studies, which is the gold standard to establish benign prostatic obstruction. It also helps us in identifying the detrusor overactivity. Now, in men with lower tract symptoms attributed to benign prostatic obstruction, detrusor overactivity is identified in 61% independently of association with outlet, the grade of obstruction. So as the age advances, or as the severity of the obstruction increases, the amount of detrusor overactivity, it keeps on increasing. So the EAU recommends to do urodynamics in patients with for whom a prior invasive treatment has failed, or in patients who have unsuccessful treatment for LUTS earlier. It is also indicated in patients who cannot void more than 150 ml, or a patient who has severe bothersome symptoms in spite of having a Qmax more than 10 ml per second. It's also indicated in patients in whom invasive therapy has been planned and who have a post-void residue of more than 300 ml. It is also indicated in extremes of age, that is, patients who are more than 80 years and who are less than 50 years, and on whom we are planning invasive treatment. So why do we do urodynamics? Urodynamics help us to find out underactive detrusor in patients who have poor outcomes. For example, if the urodynamics identifies preoperatively poor detrusor activity or detrusor underactivity, then if such a patient is subjected to surgery, then they have poor improvement in the IPSS. The outcome is very poor. The improvement in quality of life is also not good. Then the improvement in the Qmax is also not up to the mark, and the improvement in PVR also is less, as depicted by this systematic review and by the forest plot graphs. Now, is it indicated now whom to do urodynamic study? If at all, if all the patients are subjected to urodynamic study, what has been described in the upstream study, which is a randomized controlled trial of all patients, where it was randomized, half the group was subjected to urodynamics and the remaining were to the routine care without doing urodynamics. It was found that there was no much difference in the IPSS scores amongst the patients who were treated with routine care and who were subjected to urodynamics, whether they were treated with surgery or with medication. So is there any role for urodynamics then? After the upstream study, there was a subset analysis, and they found that for men with overall severe symptom scores, it is prudent to establish the contribution of voiding symptoms to the impairment of quality of life. For them, it is indicated. And then in those patients in whom the Qmax is more than 10 ml per second, urodynamic study has a role in establishing bladder outlet obstruction. So urodynamics help us to explore the functional mechanisms of lower tract, also helps us to identify the risk factors for adverse outcomes, and it provides information for shared decision making before subjecting the patient to various treatment modalities. Now, how do we manage these patients? If the patient is not symptomatic or very mildly symptomatic, then the patient can be subjected to watchful waiting. In this study by Jawan et al., it has been found that those patients who have low IPSS scores, then when they followed for 48 months, that is 4 years period, the progression was very minimal. Only 31% of the patients, they progressed at the end of 4 years. So there is a role for conservative management in patients who are mildly symptomatic. However, in those patients who have higher PSA, higher prostatic volume, and low Qmax, or a high PVR to begin with, in such patients, there is a high chance of failure of this watchful waiting. Now, the next important thing in managing this patient is to make behavioral and dietary modifications. First one is to educate the patient about their condition and how they can overcome the symptoms. Next is to reassure that these symptoms are not because of cancer as a cause for their symptom. And then to have periodic monitoring of this patient to look for their improvement, and lifestyle advices in the form of reduction in the fluid intake, or to have fluid intake at regular intervals of small quantities, avoidance or moderation of intake of caffeine or alcohol, and use urethral milking to prevent post-maturation dribble. Then reviewing the medication of the patients if they are contributing to the lower symptoms, as well as most important is the treatment of constipation, which may be associated with these symptoms. Once the patient is managed with lifestyle modifications, other important thing is pharmacotherapy in the form of alpha blockers or 5-alpha reductase inhibitors, and if in addition to them, the recently we are using antimuscarinics and beta-3 agonists. Apart from this,
Connectivity issue, I think.
relieving the problem.
Yeah.
Hello?
Yeah. There was a little break in the connection. It's fine. Continue.
Okay. The alpha-1 blockers are of, even though they have different pharmacokinetic and tolerability profiles, the clinical efficacy is similar when given in appropriate doses. The alpha-1 blockers can reduce both storage and voiding lower impact symptoms. Now, these alpha-1 blockers are predominantly seen at the bladder neck area and in the smooth muscle of the prostate. Now, the various alpha blockers are known like non-selective and highly selective. The non-selective one include phenoxybenzoin. The short-acting selective alpha blocker is a prazosin. The long-acting alpha-1 blockers are terazosin, doxazosin, alfuzosin, sustained release. And the long-acting selective alpha-1 subtype blockers includes tamsulosin and silodosin. Now, in the meta-analysis where by Boyle and et al., they showed that if the patient is severely symptomatic or when the prostate volume is more, the alpha blockers act very well. The symptom score comes down. And it has a sustained effect even after prolonged treatment. The prostate size does not affect the alpha blocker efficacy in studies when done for less than 1 year. But when it's done for longer duration, then the efficacy is seen more sustainable in those having smaller prostates. The alpha-1 blockers, they neither reduce the prostate size nor they prevent acute retention of urine in long-term studies, but they give significant relief in the short term. The IPSS reduction and Qmax improvement during alpha-1 blocker treatment appears to be maintained for longer durations, including at least 4 years. The most frequent adverse effects of alpha blockers are asthenia, dizziness, and hypotension. Another adverse effect which is seen during cataract surgery is the intraoperative floppy iris syndrome. That's why it is recommended to stop alpha blockers for at least 10 days prior to cataract surgery. Alpha blockers also they do not adversely affect libido, but can cause abnormal ejaculation, basically retrograde ejaculation, which is more seen with silodosin. So alpha blockers are effective in reducing urinary symptoms and increasing the peak urinary flow rate, which is level 1A evidence. They also show significantly increased risk of developing vascular-related events compared to placebo, that is hypotension. The alphozin, toxicin, tamsulosin, they are associated with increased risk of the floppy iris syndrome. That's why they need to be stopped prior to cataract surgery. Then they can also cause ejaculatory dysfunction. Apart from alpha blockers, we use 5-alpha reductase inhibitors. These are two types of enzymes, that is type 1 and type 2, which are inhibited. Finasteride inhibits only type 2 enzyme, while dutasteride inhibits both type 1 and type 2 5-alpha reductase enzyme. The 5-alpha reductase inhibitors, once they induce apoptosis of the prostate epithelial cells, which eventually leads to reduction in the prostate size by 18 to 28% and a decrease in circulating PSA level. But these effects are seen only after a duration of 6 to 12 months of treatment. The mean prostate volume and PSA reduction may be even more pronounced if the treatment is continued for a longer duration. Clinical effects of the 5-alpha reductase inhibitors when taken on solid alone are seen only when they're taken for at least 6 months. The finasteride data shows that there is significant improvement in the baseline when taken for a duration of more than 24 months. Similarly, with dutasteride, then taken for more 24 in the combat study, it shows significant improvement of the IPSS score compared to placebo. The difference between the 5-alpha reductase individually, if you see, compare the dutasteride and finasteride. In finasteride, almost similar percentage, by around 50% by both the drugs. So there's no much difference in finasteride or dutasteride. In addition, what has been noted is the 5-alpha reductase inhibitors, basically finasteride, can reduce the blood loss during TURP when taken for at least 2 weeks prior to the procedure. The adverse effects of 5-alpha reductase inhibitors include reduced libido, erectile dysfunction, and ejaculatory disorders. So there is a strong recommendation to use 5-alpha reductase inhibitors in patients who have moderate to severe symptoms and who have a prostate volume more than 40%. The effect is more seen in larger prostates compared to smaller prostates. The other drugs which are used in the treatment of LUTS secondary to BPO are phosphodiesterase 5 inhibitors, that's PDE5 inhibitors. These help to increase the blood perfusion as well as oxygenation in the lower urinary tract and hence reduce the symptom score. Only tadalafil 5 mg once daily is licensed for the treatment of male LUTS. PDE5 inhibitors, they reduce IPSS, storage and voiding LUTS, but they hardly improve the quality of life, Qmax, while they improve the quality of life. Younger men with low body mass index and more severe LUTS benefit the most from the treatment of IEF scores are also improved. So in a randomized controlled trial, when comparing tadalafil and tamsulosin, the effect of tamsulosin and tadalafil is almost comparable, while they are significantly much higher when compared to the placebo. Same thing with the BPH impact index also. Compared to the placebo, both tamsulosin and tadalafil, they have significant improvement in the BPH impact index, but amongst themselves, they are quite comparable. In a randomized, in the systemic review of the PDE5 inhibitors, what has been noted is compared to the placebo, the PDE5 inhibitors, they significantly improve the IPSS score. Also, they significantly improve the IIFS scores. That is, they significantly improve both storage and voiding symptoms, as well as the erectile dysfunction is improved. While if you see the Qmax improvement, there is no much difference compared to placebo. So the adverse effects of PDE5 inhibitors include flushing, GE reflux, headache, dyspepsia, back pain, and nasal congestion. Tadalafil is contraindicated, or PDE5 inhibitors are contraindicated in patients using nitrates, in patients with MI within the last 90 days, patients with unstable angina, and patients with NYHA, New York Heart Association class 2 or greater heart failure, in patients with uncontrolled arrhythmias, in patients with stroke in the last 6 months. Also, it's if the patient entry ischemic optic atrophy, neuropathy with sudden loss of vision is noted in this, then PDE5 inhibitors are contraindicated. So PDE5 inhibitors significantly improve IPSS and IIFS score, but not Qmax, and they are strongly recommended in patients with moderate to severe LUTS, with or without erectile dysfunction. Other drugs which are used are the plant extracts, that is phytotherapy. Herbal drugs preparations are made of roots, seeds, pollen, bark, or fruits of various trees. The relevant compounds within these herbal therapy include phytosterols, beta-cytosterol, fatty acids, and lectins, which are presumed to have anti-inflammatory, anti-androgenic, and estrogenic effects. They also tend to decrease the sexual hormone binding property and have inhibit aromatase, lipoxygenase, growth factor stimulated proliferation of prostatic cells, alpha blockers, and 5-alpha reductase also inhibited. And in only hexane extracted Serena repens has been recommended by the Herbal Council. In a study which compares most of this phytotherapy with placebo, meta-analysis done by Barry et al. In 2011, which is published in JAMA, it hardly shows significant improvement in the symptom score when compared to the placebo. However, the recommendation by the EU is to use this in patients after counseling them about their efficacy, and if the patient still wants, it can be recommended. But however, the patient has to be informed that the efficacy is limited or modest. If the patient also has overactive bladder symptoms, or if the patients have frequency, urgency, and urgent incontinence symptoms, then we can utilize muscarinic receptor antagonists. The M2 and M3 receptors are predominant in the recruiter. Urinary tract symptoms in men are caused by the prostate, so should be treated with prostate-specific drugs. This was the earlier thing which was believed, but now we can also utilize tolterodine or sulfenacin for treating overactive bladder symptoms. So tolterodine significantly reduces the urgency incontinence, as well as it reduces the daytime and 24-hour frequency. It is also responsible for reducing the nocturia and urgency-related voiding. Sulfenacin also has shown significant improvement in the perception of bladder condition scores, also in significant improvement in OAB question scores. So when antimuscarinic agents are combined along with the alpha blockers, there is significant improvement in the IPSS compared to the alpha blocker alone. So this shows that when compared in the various studies, when they are mixed, there is significant improvement compared to when alpha blocker has been used alone or at the plasma. So antimuscarinic drugs have shown adverse effects like dry mouth, constipation, nutrition difficulties, nasopharyngitis, and dizziness. What was worried about before the use of intramuscular drugs was that patients may land into retention of urine. However, it has been noted that the patients will, unless until they have significant PVR, will not land into retention of urine. So it has been recommended to use antimuscarinic agents in men with moderate to severe LUTS who mainly have bladder storage symptoms. And it is recommended not to use antimuscarinic overactive medications in men with a high post-void residue, that is residual urine of more than 150 ml. Another drug which has been utilized are the beta-3 agonists in the form of mirabegron. This beta-3 receptors are predominant in the smooth muscle cells of the detrusor, and their stimulation induces detrusor relaxation, which reduces the overactive bladder symptoms. The adverse effects of mirabegron include hypertension, headache, and nasopharyngitis. Mirabegron is contraindicated in patients with severe uncontrolled hypertension. Now, when mirabegron has been utilized along with the alpha blocker, it shows a significant improvement in the IPSS score and compared to the baseline. However, the changes in the mean PVR volume and Qmax were not clinically meaningful. It basically affects only the IPSS score, but the Qmax is not affected by addition of mirabegron. So, use of beta-3 agonists in men with moderate to severe LUTS is indicated in patients who have bladder storage symptoms. Now, various combination therapies have also been utilized in the form of alpha blocker along with alpha reductase inhibitors. This is used, alpha reductors are added to alpha blockers in patients with large prostate volume so that their disease progression is reduced. Similarly, alpha blockers are mixed with antimuscarinic agents to improve the storage symptoms, and when the alpha blocker alone are not or they are unable to reduce the storage symptoms. Similarly, alpha blocker has been combined with beta-3 agonists also in patients with persistent storage symptoms after alpha blocker monotherapy. When the patients fail to respond to the medical management, they are subjected to surgical treatment in the form of either open prostatectomy or minimally invasive treatment, endoscopic treatments of the prostate. The other indications include acute renal retention, bleeding, bladder calculus, recurrent infections, renal insufficiency, or if the patient wants a surgery over medical management. So basically, this is a flowchart which indicates how to approach these patients with lower tract symptoms. If the patient has bothersome symptoms, then we have to rule out nocturnal polyuria, and if that is not there, and we should assess whether the symptoms are related to storage, whether they are predominant. If yes, then we have to go for lifestyle modification or the antimuscarinic agents for the treatment of the patients. If storage symptoms are not dominant, then we have to look at the prostate volume, whether it is less than 40 or more than 40. If it is less than 40, then alpha blockers can be utilized or PDE5 inhibitors can be utilized. Then for residual storage symptoms, we can add antimuscarinic agents or beta-3 agonists. If the patient has a prostate volume of more than 40, then and wishes to be on long-term treatment by medical management, then 5 reductase inhibitors along with alpha blockers are helpful in relieving the lower tract symptoms. So with this brief background of the pathophysiology of the lower tract symptoms, as well as what all drugs can be utilized for the lower tract symptoms, let us have few case scenarios and how to approach the patient. The first patient is a 72-year-old retired bank employee, a hypertensive who was well controlled on calcium channel blockers. He complained of frequency of every hourly, urgency without any associated incontinence, and nocturia of 3 to 5 times, hesitancy, he presented with these symptoms, and for further probing, he complains of hesitancy, reduced stream, occasional straining to pass urine, incomplete emptying of the bladder. But he didn't have any post-void symptoms. There was no dysuria, fever, abdominal pain, or hematuria, and there were no associated bowel complaints. But his history says that he drinks around 4 liters of water every day to maintain his bladder health. On examination, he has blood pressure of 130/90. His urinary bladder was not palpable. His external genitalia were within normal limit. The urethra was, meatus was quite wide. Prepuce was healthy and retractable, and urethra was supple. On digital examination, he had a grade 1 smooth, non-tender gland with normal anal tone, and focused neurological examination was within normal limits. Now, on IPSS scoring, he has a score of 28/35. That means he was severely affected. He has severe symptoms. His predominant symptom was frequency and nocturia, which were most bothersome for him. When the same patient was assessed using the LUTS questionnaire, his predominant symptom was again frequency and nocturia, that is storage symptoms, and the amount of botheration with these symptoms was 10 out of 10, while other symptoms which has significant botheration were urgency, which has a bothersome of 8 out of 10, incomplete emptying, which was 7 out of 10, and a weak stream, which was bothering him 6 out of 10 times. So if we look at the symptom score, then he is having both storage symptoms as well as obstructive symptoms. His urine analysis with which he came to us was within normal limits, and the culture was, there was no growth, and the ultrasound which was done when he came to us also had showed prostate volume of 24 cc, a small gland, and a urinary bladder with pre-void volume of 125 ml and a post-void volume of only 15 cc. The bladder, when is not very thick walled, the thickness was within normal limits. The upper tracts were also normal. The patient was asked to keep a frequency volume chart, which showed average daily intake of 4.2 liters. Average daily urine output was 3.5 liters. The frequency was, on an average, was every 2 hours, and used to get up 4 times from sleep to pass urine. The average bladder capacity was around 200 ml, and the maximum bladder capacity was 320 ml, and the nocturnal urine output was moderate the intake of caffeine, which was consuming in more quantity. So on follow-up with this behavioral modification, the patient was relieved of frequency nocturnal urges, which was primarily significantly bothersome symptoms. But later on, he still had bothersome reduced stream. So uroflowmetry was done, which shows a borderline obstruction to the flow of urine. Maximum flow rate was 16, which was a borderline. His bladder capacity was, means void volume was 450 ml, and the post-void ratio of 51 ml. So he was started on alpha blocker to address his weak stream. So on further follow-up, he significantly improved, and he was advised to continue alpha-1 blocker therapy. So here the prostate volume was less than 40 ml. So there was no need to add any alpha reductase inhibitor. Now the second case is a 59-year-old agriculturist, diabetic on oral hypoglycemic agents, had mild dysuria, urgency, intermittent urgency incontinence, frequency 2 to 3 hourly, nocturia 2 times, no hesitancy, the stream was variable, he had no straining or no terminal, he also complained of terminal dribbling of urine, occasional sense of incomplete voiding or incomplete emptying of the bladder, no post-void dribble. He had no history of fever, abdominal pain or hematuria. He gave history of constipation. He also had an episode of urinary tract infection 3 years back, for which he had received antibiotics. On examination, he was afebrile. His BP was 120/80 millimeter of mercury. Urinary bladder was not palpable. External genital were within normal limits. On distal rectal examination, he had a grade 3 gland, firm, smooth, non-tender, with normal inner tone, and his focused neurological examination also within normal limits. If on IPSS symptom scoring, he was mainly bothered by urgency, which has 5 out of 5, while the other symptom which was worrying him was the weak stream, which was affecting his quality of life. He had moderate severity of symptoms. On LUTS questionnaire, his primary bothersome was again urgency, along with urgency incontinence. He was also having some post-void dribble, which was 1 in 4 when asked for, and which had a bothersome of 4 out of 10 times. And frequency of again was bothersome. His urine analysis was within normal limits, and culture had no growth. His ultrasound showed a larger gland, which was projecting into the bladder. So it was measured around 45 cc. The upper tracts were normal, and the bladder wall thickness was acceptable. His Uroflow showed a Qmax of 11.5 ml per second, average of 4.5 ml per second, avoided around the avoided volume was 233 with a post-void ratio of 45 ml. So he was started on alpha blockers along with laxatives. On follow-up, he had relief of dysuria, stream improved, but he had persistent urgency without incontinence. The incontinence which was there initially was relieved, but he had persistent urgency. He was subjected to a systematic examination, which showed a normal stable philic phase without any detrusor overactivity. The voiding phase showed a good detrusor activity, sustained detrusor contraction, but a poor flow of urine during the systematic study. So alpha blocker was added. In addition to that, mirabegron was added to his alpha blocker to relieve the urgency. On follow-up, the urgency was relieved and his quality of life was improved. So the understanding of the lower tract symptoms help us in identifying which patients need treatment, how behavioral lifestyle modification can help the patient, and we can have a judicious use of the pharmaceutical agents in managing the patients. The take-home message is lower tract symptoms is not a diagnosis; it's a manifestation of multiple etiologies. Clinical evaluation is key step in assessment of lower tract symptoms due to BPH. We have to inform the patients the risk of progression after our initial evaluation. The clinical evaluation investigations will help us in guiding the ideal treatment, like whether the patient has to switch to watchful waiting or pharmacotherapy. Urodynamics is indicated in non-responsive patients and helps us in understanding the lower tract pathology in that individual patients. Patient education, behavior modification are crucial in the management of the patients. Judicious use of pharmacotherapy help in relieving the lower tract symptoms in the affected patients, and surgical intervention in case of complicated LUTS management. Thank you.
Yeah, Dr. Nili, thank you very much. Now, if you can just pay attention to the questions which have come in the chat box. I'll just come one by one. Let me bring to you the first question, which is from our dear friend and colleague Prashant. Prashant is Zonal Secretary of a Western chapter of USI, as well as a very, what you can say, key figure in making the guidelines for patients with BEP under the ages of USI. He has posed the question to you that should we add retention of urine as one of the voiding symptoms?
Retention of basically it's a progression of the disease, sir. Retention itself is a complication rather than symptom. So if it's a progressed this one where we need to treatment. It mandates treatment where we cannot keep on observing. There is no role for watchful waiting. It can be added as a storage symptom.
Yeah. So your answer is correct, because this is something like which shows one of the type of symptom, but we don't know whether it is the retention is spontaneous, precipitated, or the underlying cause. It is very difficult to pinpoint whether it is along the course of the pathophysiology of LUTS due to BEP. So that is the problem in understanding. Say a patient has taken some sort of drug, or he is constipated, or he has a febrile episode, ends up in having a retention urine, which may be some sort of having a different entity, which may respond to some sort of medicine and the catastrophe trial fine. But again, the PV, the high PVR and retention urine are taken as a sheer marker of obstruction. That is what Dr. Neely has pointed out. But again, it shows what you can say, all the questionnaire which we take, whether we take IPSS, BPSS, Danish or ICQ male, they will have some drawback till we have some sort of additions or some sort of suggestions coming from the people who are daily dealing with these cases, and that's how. But again, definitely space, or there is definitely what you can say spot for adding on to the pre-existing questionnaire scores. Okay, now second question to you, Dr. Neely, is that is from Dr. Abhay. When to do urodynamics? I think you have very aptly described the indication of urodynamics, but if for Dr. Abhay's sake, can you repeat the indications?
Urodynamics is recommended when we have extremes of age and we intend to treat them. That is, it is less than 50 or more than 80. That is one. Or if the previous treatments have failed, if we treat them without doing urodynamics and they have failed, we need to assess those lower tract symptoms. We have to do urodynamics and assess why the treatment failed and how we can help them. In addition, it is indicated in those patients who have a very large PVR and or in those patients who are severely symptomatic, and in those patients who have Qmax of more than 10, and in spite of that, they are severely symptomatic. For all these patients, urodynamics is indicated to assess why the symptom means the treatment has failed earlier, or how we can help them in a better way, or to guide the further treatment.
Yeah, I think Abhay, your question has been answered, but at the same time, you should note the upstream trial which Dr. Neely has shown. This is some sort of what you can say a randomized trial on the patients of LUTS having a routine care treatment and others having a urodynamics along with the routine care treatment. So they have some conclusions, and they have some indications for patient having urodynamics. But this again, the paper has come from Paul Abrams from Bristol, where there's a routine to do urodynamics for all the patients. I think I'll just let me go back to Prashant. Prashant, you have your hands raised. Please tell me.
I raised the hand because Dr. Abhay wanted to know when to do urodynamics, before diagnostic cystoscopy or after diagnostic cystoscopy. That is his question. Now, if we answer this question, see, diagnostic cystoscopy per se doesn't have a significant role in evaluation of BPH patients. Rather, urodynamics does have a diagnostic role in a patient of BPH. So urodynamics will always come first as far as possible. When will you do a diagnostic cystoscopy? When your diagnosis is in doubt or when you want to plan a surgical treatment. So I think the answer to his question is we will do urodynamics first whenever it is indicated.
Agree, sir. If there is a history of hematuria or if you suspect stone disease, then the cystoscopy comes prior to the urodynamics. Means first we need to rule out those conditions. If it is purely because of bladder, our suspicion is only bladder outlet obstruction secondary to prostatic enlargement, then urodynamics comes prior to surgical intervention or prior to cystoscopic evaluation.
Now I go to back to Abhay. Abhay, again, when we are talking of all these things, you should keep in mind you have two entities in a male patient with LUTS due to BAP, where we try to figure out two things. One is the investigation to assess the size of the enlargement of prostate, and number two is to assess the obstruction caused by the prostate. So urodynamic is one of the investigation which has a different components. You have the questionnaire, you have the flowmetry, you have the bladder diary, you have the cystometry findings, and then you have the other Schaefer nomogram, PER and all that, which added on to the PO, the bladder contractor index and bladder outlet obstruction index, give an idea. So that was in addition to what you have asked. I move back to the next question, which is from this is a question about the duration of treatment with alpha blocker. How long you can keep on counting with alpha blocker? Do you play with the alpha blocker? You keep the patient on, you stop it for a while, you reduce it for a while? That is the question raised. And number two, the incidence of a floppy iris syndrome. Does stopping will change the incidence of floppy iris syndrome?
Sorry, sir, can you repeat the second question, sir?
It is the question related to whether it will change the incidence of floppy iris syndrome if we stop the alpha blockers before that.
Yeah. Regarding the first question, how long the alpha blocker have to be taken? As long the patient is getting symptomatic relief, we have to continue the alpha blocker, because the moment the alpha blocker is reduced, it's withdrawn, the patient becomes symptomatic. Even if the patient is on alpha blocker, the disease tends to progress. What has been shown in the various studies is, with the time, the effect of the alpha blocker, even though it is sustained for longer duration, especially with smaller prostates, but with those with larger prostate, they tend to progress. So if the patient has as the age advances, or the patient has large volume prostates, or if the initial post-radiation is on the higher side, then they tend to progress and the result is not well sustained. In those patients whom we want to withdraw alpha blockers, the other way is to add, and those patients with larger prostates, 5-alpha reductase inhibitors can be added to the alpha blockers, so that the risk of progression or the progression is reduced, so that they have a sustained effect of the alpha blocker for longer duration. And regarding this floppy, sorry, sir.
Yeah, continue.
And regarding floppy iris syndrome, if we withdraw the alpha blocker for more than 10 days duration, the incidence of floppy iris syndrome is much less compared to those patients who are operated while they are having alpha blockers.
Okay. I'd like to ask, do you get a routine consultation from ophthalmology department? They are planning a cataract surgery, whether we would like to stop the alpha blocker before that. And what is your view on that?
So off late we are getting those consultations. Like off late they are taking more this one, but initially we never used for the. I'm practicing since 15 years. We are receiving this consultation only since past 1.5 to 2 years, not more prior to that.
Okay, so what do you do then?
So we ask the patients to stop the alpha blocker before this one, and if the patient landings for retention, then we have to catheterize. Otherwise, it depends on the severity of the patient. If the patient is, we can in fact start them on PDFA inhibitors if required to reduce for the patient's symptoms, if the patient is severely symptomatic.
Okay. Yeah, so usually people stop alpha blockers 2 weeks prior to cataract surgery whenever the ophthalmologist gives the consent. Now, the next question is the duration of treatment with dutasteride. That is question from Abhay Gaur. How long you can give?
The symptom for the 5-alpha reductase inhibitors, either finasteride or dutasteride, unless until we give the patient for minimum of 6 months, we will not be able to see any clinical effect of those drugs. Whenever we add pyruvate reductase inhibitors, we think we have to counsel the patient that they have to take the drug for long term, then only they are of use. For short term, they are not of much use. So if the patient is getting relief, then it has to be continued. There is no respect for that.
Dr. Suraj and Dr. Neeli, just I like to add here only. Let us assume you have alpha blocker along with the say dutasteride or finasteride or mirabegron or antimuscarinic or say PD5 inhibitor. Do you continue with the combination for ever, or you play with the combination, reduce one and see the response after 6 months or so? What is your routine?
So routinely here, we continue the same combination as long as the patient is getting relief. Or if the patient has any side effects of any particular drug, then we tend to withdraw that or change the combination. Otherwise, as long as the patient is getting relief, we continue the same.
Prashant?
Yeah, I just wanted to add here that whenever a patient is a candidate for pyruvate reductase inhibitor, most of the times he will be a candidate for pyruvate reductase inhibitor for the lifetime, because the prostate is going to grow and he will need to take these drugs as long as he doesn't have any complication. Now, as regards the alpha blocker, we can play with alpha blocker. We can either stop, decrease the dose, or change the alpha blocker depending upon how he responds symptomatically to stoppage of the drug. If the stoppage of the alpha blocker doesn't cause much bother, then we can continue stopping the alpha blocker. That's what my impression is. And as regards the both these drugs, their efficacy and safety has been proven beyond 6 years as per the literature. So in my patient, most of the times when a patient is on combination treatment, after maybe 1 or 2 years of combination treatment, I withdraw the alpha blocker and then see what happens. If he's happy, we continue only with the finasteride dutasteride.
Dr. Neeli, the question from Stephen Silo. In behavioral and dietary modification, which is the first form you give for a patient, the LUTS to BHP, it said that you have to assure the patient that your symptoms are not due to cancer. So you need to do some tests, or how do you make sure that you convince the patient that these symptoms are not due to cancer?
So first is convincing. It need not always be about the test. It is like how you put forth the things. First is your evaluation should say that there is no malignancy. On clinical examination, there should be no doubt of malignancy. Then you can counsel the patient that these symptoms are not because of cancer. It's not mandated that we have to do a test and prove it and then say that it's not because of
cancer. Do you include PSA as a routine in patients with LUTS due to BHP?
Okay. No, not at all. It's not indicated also.
Okay. Okay. Till what volume of post-wet residual urine is mirabegron advised? That is related to the your second case scenario.
Till 150
what
ml.
Volume of PVR?
Usually we avoid patients with more than 100 ml post-wet residue. In those patients with less than 100 ml post-wet residue and are severely have a lot of storage symptoms, we do add mirabegron.
Okay, so is basically his doubt should be regarding anti-muscarinics rather than beta-3 agonist. Am I right?
Probably.
Yeah. What is the role of alpha blocker and 5-alpha reductase inhibitor in patient with acute retention?
In acute retention?
Yeah.
In acute retention, in any acute condition, is the alpha blocker which has a role. The pyruvate reductase have a role only when given for longer duration. It may help in reducing the vascularity if you are planning for surgery in the next 2 to 3 weeks. That's the only role for pyruvate reductase in acute setting. Otherwise, it is helpful only when taken for longer duration.
Yeah, no, I think I vaguely remember when this Cystoscopy was being marketed by different companies. They were mentioning about the very quick onset of action of this drug. Meaning thereby that patient who are coming with acute retention on office based only, you can give the Cystoscopy 8 milligram and give a catheter-free trial. But of late, we don't see many articles mentioning this type of trial for especially the psilocin. It was mainly for psilocin because of quick onset of action. But we do see this type of alpha blocker being used, especially to assist the what you can say the results of avoiding cystogram when the patient is being evaluated for urethral stricture when you are doing ascending ureterogram and avoiding cystogram to open up. But for sure, I think I have got a comment from Surya Prakash Vade also. There's no role of combination of flow blocker and 5-ARI in acute tension. But I have come across a few articles, especially with relation to psilocin 8 milligram, where they have used this drug for catheter-free trial in acute tension urine. Now I come back to the questions. Do you advise PDE5 inhibitor based combination upfront?
They are indicated in patients who are also have complaint of erectile dysfunction. But otherwise, usually we prefer alpha blockers because the disadvantage, even though the PDE5 inhibitors they improve symptom score, they never improve the Qmax. It has been shown that they don't improve the Qmax. That's why we prefer alpha blockers over the PDE5 inhibitors. While if the patient has a history of erectile dysfunction, is also concerned about it, then we definitely use PDE5 inhibitors as the first line of therapy.
Yeah, so Abhishek, the PDE5 inhibitor doesn't improve the what you can say. You have a storage subset, you have a voiding subset of APS. It doesn't have much effect on the voiding. It does improve storage subset score of LUTS, but mainly useful in young patient in LUTS, where you don't want to give alpha blocker because of the incidence of RI, and then you can give this drug alone. As a combination, again, what is only one randomized study where they have used tamsulosin and tamsulosin with the PDE5 inhibitor. Only one study is there where it has a mild improvement in the improvement of the IF score in these patients. Dr. Neely, question about non-selective alpha blocker, Trazodone, doxazocin in your practice. If yes, when?
So nowadays, with its highly selective alpha blockers, we are hardly using doxazocin and prazosin. But if the patient is already on these drugs by the physician for control of hypertension, we do continue.
Yeah, I think I agree that most of the time when you see these people, patients taking this alpha blocker is either by physician or the cardiologist who are managing this patient in their practice. Prazosin Miniplex XL is being written by them. I have seen them using Trazodone. Doxazocin I have not seen many physicians or cardiologists using that. Again, the alphazocin in young patient, is it useful? This is a question from Alok.
It is useful in relieving the lower tract symptoms, and there is a claim that it helps in maintaining the sexual activity, and it has a lesser incidence of retrograde ejaculation compared to the tamsulosin and silodosin. But our clinical practice says the amount of means the retrograde ejaculation is similar in even patients taking the alphazocin.
Yeah, absolutely, I agree with that. It is the marketing strategy which brought this alphazocin over the tamsulosin and other medicines in just mentioning that it is associated with lesser incidence of retrograde ejaculation, which probably is not in actual practice. This is question from Abhay. Okay, again, the same whether you can give trial without catheter after AUR by giving alpha blocker.
Yeah, it can be.
And the treatment duration and dosage of mirabagrone.
The treatment is initially we have to give at least 2 weeks and the mirabagrone, and then withdraw it and see if the patient has recurrence of storage symptoms. It can be re-added, but has to continue on the alpha blocker treatment for the prostate-related lower tract symptoms. The addition of antimuscarinics in general, or the beta-3 agonists, it depends on how much the patient is affected by the storage symptoms.
Absolutely.
It can be given for 15 days duration to up to 6 month duration, depending on how severe the storage symptoms are and whether they are recurring after stopping of the treatment.
He wants to know what dose we give, 25 or 50 milligram mirabegron.
We start with if the patient is has mild storage symptoms, then we can give 25 milligram twice a day. If the patient is severely symptomatic, we can start upfront with 50 milligram twice.
Prashant, you want to have any comment? Prashant?
The question that is asked by one person is when to give trial of wedding after AUR, after giving alpha blockers. The consensus duration is 3 days, but there have been trials where a single dose of alpha blocker and immediate catheter removal, and after 7 days, also 5 days, also described in various trials. But the consensus statement for removal of catheter is after 3 days treatment of alpha blockers. But there is no specific evidence to come to that figure of 3 days. But 3 days is the commonest prescribed thing.
So even if you see in those patients not having catheter also, if you see the various trials, the symptom score improvement by 3, it happens by the 7 days duration. And by 5, it happens up to 2 to 3 weeks duration. The symptom score improvement. So at least it has to be given for at least 3 to 7 days prior to giving catheter-free trial.
Yeah. So the another question is when you specifically prefer mirabegron over antimuscarinics? There's a question from Abhishek.
It depends on the side effect profile for the patient and whether which one he tolerates better. If the patient has a both drugs are known to cause constipation actually. Well, antagonists have more constipation compared to the beta-3 agonists. But if the patient has the side effect profile is a bit different. In hypertensive patients, we cannot use mirabegron. Mirabegron is contraindicated patients with uncontrolled hypertension, where we use antimuscarinics. But in the other patients, we can use either.
Yeah. So I think we are coming to the last question, which is a comment only. I think this is a question from Dr. Korean George. Whether coffee, tea, alcohol to be restricted in overactive bladder. That means probably you mentioned about when the patient have predominantly storage LUTS. I think you have mentioned that. Would you like to answer? Yes, coffee, tea, and alcohol, because this problem is related to a different age group, 50 plus, 60 plus. So your comments on that?
Basically, these increase the volume intake as well as they can have diuretic effect per se. So they increase the amount of urine produced and can worsen the lower back symptoms. So it is advised to either reduce or take the caffeine in moderation. And they should avoid binge drinking, which can precipitate acute retention of urine.
Yeah. Now, question is from Abhay. He wants to know from your experience, not evidence-based medicine, but experience-based medicine, what will be your first drug of choice, Cystoscopy or tamsulosin?
I usually use tamsulosin.
You usually use tamsulosin.
Okay. We use tamsulosin unless the patient has a cardiovascular risk is there. Then we prefer to use silodosin or tamsulosin. It is found to be more safer in patients with cardiovascular side.
But you will agree that the retrograde ejaculation is much more in Cystoscopy as compared to tamsulosin.
Definitely, sir. Silodosin has much more retrograde ejaculation. That's why we prefer using tamsulosin as a primary drug in most of the patients.
Yeah. And patients are worried about that. Am I right?
Yeah, especially younger patients and who are sexually active.
Just adding from my end, this is regarding various alpha blocker, do you specifically look for any alpha blocker which has some positive effect on the nocturia component, which is a very bothersome, which doesn't get relief with any of these alpha blocker. Patients are always open. Everything is improving, but he is not getting relief from nocturia. Apart from trying the behavioral and lifestyle modification, in your experience, you find any particular alpha blocker which is useful in nocturia component?
No, sir. I find all the alpha blockers are the same. And the behavioral modification is the most important thing which helps in getting rid of the nocturia. And if it's really persistent, then we have to evaluate whether the patient is having nocturnal polyuria. If the patient has so, then we have to add them desmopressin for treatment of with keeping the side effect profile in mind.
Yeah, question is from Abhishek. Is UDS indicated for every tension patient with residual urine of more than 300 ml? I think you have made it clear your indication. That is one of the indication in EAU guidelines. Your comment, you would like to clear this doubt again?
Sir, it is indicated, but it's not a mandatory test. What is, it's a recommended test so that we understand the bladder lower impact in a better way. But even if you skip the urodynamic study in such patient and go ahead with treatment, it is nothing wrong as long as the patient is getting relief.
Now, while we were discussing about the alpha blocker, I think we have comments from Surya Prakash that naftapadil was marketed for predominant nocturia. Actually, that was in my mind when I was talking. But the problem with this drug was of severe GI symptoms. Initially, when it came with a lot of fanfare and probably some sort of the only drug which used to take care of bothersome nocturia. But I don't think it is being marketed now. And this I remember Intas brought this into the shower market. So now we have not seen anybody marketing this drug. But I know it is available and it does exist, but we are not using it. I have the occasion to use this drug when it was continued for long. They stopped it for the majority of the time. It was because of the adverse effect profile, very severe GI symptoms. Again, the Alok has mentioned about the solifenacin evening time for nocturia when you can give solifenacin. Again, Alok nocturia, he has mentioned. Dr. Neely, would you like to answer? Solifenacin evening time for nocturia?
All these are long-acting drugs, whether they take in the morning or evening, they have a long duration of action.
Yeah.
When in general they reduce the frequency, it reduces the frequency and also to certain extent the nocturia. But unless until the patient also does behavioral modification, the nocturia will not be addressed.
Yeah, actually, when he was talking about how the lifestyle modification and all that, when you have these people, especially with the, you can say, cardiovascular disease or some other associated disease, they are taking a lot of medicine. So we have to keep in mind that all these medicines are not clubbed together in the night when they'll be taking one tablet with a lot of water, and it is. So it is very important. Whenever these patients come, you tell them to just get all the medicines list and the medicine there and ask them practically which medicine and give them a proper profile. These medicines are to be taken, and after 6:30 or 7 o'clock cut off line, which fluid you have to stick, which you are not to take, which includes even the fluids which you are taking along with the drugs. Am I right, Dr. Neely?
Yes, sir. Very much.
Yeah. Prashant has given one comment that behavioral therapy works for best for nocturia. Totally agree with you. Nothing like behavioral therapy which makes more symptomatic relief than with the current medication, especially for nocturia, because the minerin or desmopressin is hardly written in this, especially the nocturia component, keeping in mind the indication, specific indication, and the what you can say, the estimation of sodium and the safety profile of this drug. It is hardly in prescription for this patient, and when you have a predominantly nocturia or nocturnal polyuria in these patients. Dr. Ely, your comments, sir?
Sir, in those patients with nocturia, sir, we have to really assess the patient. First thing is we have to look for the obstructive sleep apnea. We have to have a strict bladder diary to document that they really have a nocturnal polyuria before starting them on this desmopressin. Even in majority of the patients having nocturia, and if it's because of nocturia, it's because of the obstructive sleep apnea syndrome, which if you treat that, then this polyur itself is taken care of, and we need not put them on this desmopressin.
Yeah, thank you, Neeli, and you have probably answered all the questions. Let me check whether something is there. Yeah, you have a few messages for appreciation for your talk and with thanks. I think I have with Prashant and Dr. Pankaj also is there. Dr. Pankaj, you have something different to contribute to what he has done, especially keeping in mind the few questions which were raised by residents from your experience. We know that you do a lot of work on BPH, you do a lot of minimal invasive treatment for this condition. You have something to offer to our residents, especially to the question which they pose?
No, sir. Means I agreed with a lot of things which were said.
Yeah.
In my practice, I do not insist on continuing the drugs lifelong. Means even 5-alpha reductase inhibitors as well as alpha blockers. I would try, especially alpha blockers, I would stop in patients whose flow rates are very good. Say if on follow-up I find flow rates to be more than 15 ml per second, then I try to stop them. A lot of patients may not need these alpha blockers again for a period of 6 months to 2 years. And whenever they need, it can be restarted. So at least 20-30% patients, we can stop alpha blockers. I regularly give trial without, say, catheter by giving alpha blockers, and especially in secondary retention of urine, it works very well.
Absolutely. So that's all. And with this, I have
one more thing, sir. With a lot of patients with say the use of PD5 inhibitors primarily for lower uterine symptoms has increased a lot. I realize that if you give patient a choice, that probably there is a drug which could work on both on LUTS as well as on sexual functions. A lot of patients tend to choose PD5 inhibitors. Though literature says that the uroflow doesn't improve significantly by PD5 inhibitors, we are just compiling our data and it seems to work fairly well.
Okay. Dr. Pankaj, I have little different in one of the pilot study which we did with the 3 groups, tamsulosin with placebo, tamsulosin with tadalafil, and tadalafil with placebo. We have very poor results in tadalafil arm. Okay. We had very poor, except for IEF score. It didn't work at all. There was a totally what you can say unsatisfactory results in both the IPCS, VPSS score. So only thing is IEF was there, but that was also not coming that good. So we have to just keep this trial, and it was not this was for all the age groups. So probably we didn't have a younger patient, especially just to figure out whether it will help more in younger patients, especially in the 6th decade, 50 to 60. Probably that power was from 6th decade to whichever inclusion criteria fits in. It included patient in 70s and 80s also. I think while we are finishing, there's another question. Tamsulosin 0.2 milligram.
If the patient is getting effect with 0.2 milligram, it is worth continuing.
Yeah, I think this.
Sometimes what we have seen is if the patient complains of orthostatic hypotension, by reducing the dose from 0.4 to 0.2, they tolerate it well.
Yeah.
And they have their symptomatic relief as well as they have lesser side effects of orthostatic hypotension.
True.
Absolutely. I think this was brought basically for reducing the adverse effect, as well as some people have used 0.2 milligram in female with voiding LUTS. So that was also another indication where used to give. We had one of our study published in female with 0.2 and 0.4, but that is off the. I think with this, we'll on behalf of Indian School of Urology USI, the central office of USI, Dr. Neeli, great thanks to you. A very comprehensive discussion. You brought what you can say the science into the pathophysiology of the LUTS, as well as evaluation and the management. I think you topped it up nicely by discussing 2 index cases, which will probably enlighten and give more, what you can say, practical knowledge how to manage a patient, male LUTS due to BHP. And I think we have a second part pending, which will be the invasive management of male LUTS that we are keeping pending for the next session sometime later. With this, thanks Dr. Shant and Dr. Pankaj. Thanks Kiran, Navneet. Thanks all the USA members and the postgraduates who have logged in for this program. Thank you very much. Thank you, Dr. Nidhi, once again. Good night.
Thank you, sir.
Thanks, sir. Thank you. Thoroughly enjoyable. Thank you, sir.